Hello, my name is Terry Cunningham, and I am the chair of the Liver Coalition of San Diego. I'd like to welcome you to another informational seminar dealing with liver disease. We have experts providing very useful information. The Liver Coalition was founded last year to fill the void created during the early pandemic, actually. Now all funds raised stay in San Diego and do not go to a national organization. Please look at our website for other webinars and information. That'll be very important for you, especially if you have questions about other liver diseases. I'd like to thank our attending sponsors. And first of all, I'd like to ask Greg Cohen from Dynavax to say a few words.
Good afternoon, everyone. My name is Greg Cohen with Dynavax Technologies, manufacturer of Heplisab-B, the only 2-dose, 1-month hepatitis B vaccine that's quickly becoming standard of care due to its increased protection rates as well as series completion. Thank you again for joining.
Thank you, Greg. And now we're going to have a short video from Ascites, and as another sponsor of ours. We also have a video from AbbVie. I'd also like to thank Gilead and Exelixis for their sponsorship. Without all of these pharmaceutical companies, we would not be able to produce these webinars for you. And please remember that today's webinar is for educational purposes only and should not be considered medical advice. Please check with your doctor for medical advice. Now I'd like to introduce our moderator, Lisa Richards, who is with the Associate Medical Advisory Council. So Lisa, please take it. Thank you.
Thank you so much, Terry. It is a great honor to be here tonight with you, and I have the distinct pleasure of introducing Dr. Heather Patton. Dr. Patton received her doctorate of medicine at the University of Michigan Medical School, and she completed her gastroenterology fellowship at UCSD, along with her advanced hepatology fellowship at Scripps Clinic. Dr. Patton is a fellow of the American Association for the Study of Liver Disease, and this is one of the highest honors a physician can be given. It is awarded to physicians who have made a significant contribution to the knowledge and or practice of liver and biliary disease and who are considered leaders in their field. So it is a great pleasure to have her here tonight to share her knowledge, and she'll be talking to you this evening on talking to your doctor about cirrhosis and complications. Dr. Patton?
You can hear me now, yes?
Yes, now we can hear you.
Okay, great. Well, thank you very much for the kind introduction. It is a great pleasure to be here presenting this webinar on something that is very important to me in my practice, and hope that this provides all of you with a foundation that can guide your discussion with your liver providers. I know that getting a new diagnosis of cirrhosis in particular, I think, can create a great deal of anxiety and confusion. And I think that when we're feeling that way, it can be overwhelming to know even where to begin these conversations, what types of things we should be asking. And often some of the visits in clinic feel very rushed on both for the providers and for the patients and their families. And so coming into the visit somewhat prepared with the types of things that you want to ask about and want to understand when walking away. I think also knowing where you yourself can find some good information. The internet has lots of information, as you're aware. Some of it is great. Some of it, I think, can be at times misleading. And so we want to leave you today as well, and on the Liver Coalition's website, with some places you can go to get good information about your diagnosis. So without further ado, let's see if this is, yes, okay. So what we're going to talk about here is shown in outline form. We're going to first just kind of define what cirrhosis means. We'll review some of the causes, not an exhaustive list, but certainly review some of the most common reasons that people can have cirrhosis. Likewise, review the most common complications that we see occur in response to cirrhosis. Some of the things that can be done to manage and treat cirrhosis. We'll touch a little bit upon the role that liver transplant can play in care, and then leave you with some resources. So first of all, let's define cirrhosis. Cirrhosis is one of those words that many people have preconceived notions about. And unfortunately, this can be a word that's associated with some shame and stigma. And so I wanted to first start by reviewing what cirrhosis doesn't mean, because sometimes people come into the clinic thinking these things, and sometimes I forget that these are ideas that people may be coming in with. And so to clarify, I'm saying that someone has cirrhosis does not mean that they have cancer. Never would have occurred to me that somebody might think that that's what that word meant, but some people do think that having cirrhosis means that they have cancer. Having cirrhosis does not mean that somebody is an alcoholic. This is a term that we really are moving away from in the medical field in favor of the term alcohol use disorder. And yes, while alcohol certainly can cause cirrhosis, so can many other things, and we'll review some of those tonight. Cirrhosis also does not mean that definitively somebody is going to need a transplant. Some people do, not everyone does, and it's truly our goal in taking care of patients with cirrhosis to do whatever we can to try to avoid people needing a transplant. So the term cirrhosis to us as liver providers has a very specific meaning, which is that there's a certain degree or severity of scarring present in the liver. And shown here in sort of cartoon forms, a cutaway of a liver that is essentially normal and healthy in comparison to one that has cirrhosis. And you can see the sort of lumpy, bumpy appearance that the cirrhotic liver has, and that is all created by the presence of scar tissue that is really scattered throughout the entire liver, which is another question sometimes people have. Is the part of my liver scarred and part of it is okay? This is really something that affects the liver in its entirety. Shown below are examples of liver biopsies. So if we look at the liver under a microscope, on the left is what a normal healthy liver would look like. On the right, you can see these blue, purpley blue bands that are surrounding kind of circular areas of liver. And that blue area is scar tissue in the liver that is dyed so that the pathologist can see it more easily. So this is what we mean when we say that there is cirrhosis. Moving on now to why cirrhosis happens. What are the causes of cirrhosis? So these are the big three. This accounts for the vast majority of the patients we see who have cirrhosis, and includes non-alcoholic fatty liver. This is a very, very common cause of liver disease. Now, fortunately, most people who get fatty liver do not go on to get cirrhosis, but some do, and so this is a common one that we see in our clinics. Chronic viral hepatitis. So hepatitis B, hepatitis C are viruses that can infect the liver on a chronic basis, and in some cases result in cirrhosis. And of course, alcohol. So alcohol can cause liver damage, liver cirrhosis. It does so typically above certain threshold of use, typically after long periods of exposure, although there's quite a bit of individual variability in terms of how much effect alcohol has on people's livers. So again, by no means an exhaustive list, but here are some of the other causes of chronic liver injury that again, don't always, but can result in developing severe scarring or cirrhosis. So there are a few autoimmune conditions. So this are conditions where your body's immune system is kind of overactive and responding to some of your normal tissue. And so this can be directed towards the primary cells in the liver or towards the bile ducts in the liver. So autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis are examples of this. There are some conditions that can be inherited that can affect the liver's health. So Wilson's disease is a condition where copper is absorbed in excess and gets deposited in certain parts of the body, including the liver. Hemochromatosis, which I know we have a webinar on as well. I did that one a couple months ago. This is a condition where iron is absorbed in excess and deposits in the body, including the liver. Alpha-1 antitrypsin deficiency is an inherited condition that can affect the lung tissue or the liver tissue, and in some cases can lead to chronic liver disease. Other, even perhaps less common conditions include conditions that affect the liver through the blood vessels. So certain clots in certain locations around the liver can affect the liver's health over the long run. There are we see this less often now with improved surgical technique, but patients who may have injury to the bile duct that results in secondary cirrhosis from bile duct injury. And in the pediatric population, a condition called biliary atresia can result in severe liver disease early in life. And we still do occasionally use the term cryptogenic. You may hear cryptogenic cirrhosis used. This means we've looked every place we know to look and we're just not sure what the cause of cirrhosis is. This is fairly common these days as we are increasingly recognize that some patients we previously may have called cryptogenic, in fact, have cirrhosis due to fatty liver. So how do we determine that somebody has cirrhosis? There's a few different ways that this diagnosis can come about. One of the ways shown here, we have an example of a CAT scan or CT scan image of a liver with cirrhosis. And so sometimes this is a diagnosis that we weren't necessarily looking for, but somebody was seen in the emergency room for an unrelated reason, had a CAT scan done or an MRI scan done or an ultrasound done, and by sort of accident or incidental, we call it, cirrhosis is identified. We can sometimes identify this through blood tests. Blood tests usually are more suggestive than necessarily definitive proof that somebody has cirrhosis, but they can certainly help point in the direction that somebody may have cirrhosis, and then we can confirm with some other testing. This device here is one that many of you may have seen or had this exam done. This is called Ultrasound Elastography, or FibroScan is the brand name for this device. It's an ultrasound-based device that uses vibration to help estimate the stiffness of liver tissue, and this can help us to identify cirrhosis in a non-invasive way. Similarly, MRI can be performed with this elastography component. So MR elastography is another way that we can find that somebody has cirrhosis. And last but not least, a good old-fashioned liver biopsy. These are examples of liver tissue with no, minimal, moderate, and severe fibrosis or cirrhosis here shown with staining. What types of things do we see on a scan that would suggest to us that there may be cirrhosis present? This can include the contour of the liver. So the surface of the liver might look a bit more lumpy bumpy than smooth and even. Sometimes we will see fluid around the liver, what's called ascites, that can identify cirrhosis. The main vein that goes into the liver, called the portal vein, can become dilated in cirrhosis, so that might be identified on a scan. We can see these blood vessels present on imaging that may not ordinarily be seen, that are called collateral vessels or varices. And finally, we can see that the spleen can become enlarged sometimes in the course of cirrhosis. So these are all sort of clues that can help us to identify that somebody has cirrhosis. Like many conditions, just saying that somebody has cirrhosis really doesn't tell the full story. As in any chronic condition, there are various sort of levels of severity or stages that people may go through. And this is one of the important aspects to clarify with your liver provider, you know, sort of getting at how bad is my cirrhosis? Where am I on the spectrum? And this shows stages. Really, in practice, we rarely refer to these stages. So unlike when we're talking about a cancer, we're saying, you know, what stage is my cancer? That's a very common terminology used. We don't use it as much in the liver community. What we often refer to is whether the cirrhosis is compensated or decompensated. And we'll explain that in detail here coming up. But that distinction you can see is important if we look at the, you know, risk of mortality or death related to cirrhosis. If we're talking about patients with compensated disease, the risk is exceedingly low, but very, very different if we're looking at patients who have had one or more decompensation events. So let's switch gears now to talk a bit about some of the complications. So first of all, I'm going to just introduce the concept of portal hypertension, which the medical physiology of this is fairly complicated, but I like to break it down into two things that we know are going on in cirrhosis that contribute to this phenomenon called portal hypertension. So when we say portal hypertension, what we mean is that the blood pressure in this main vein to the liver, the portal vein, so this is the main blood supply feeding the liver, the pressure inside this vein is elevated. It has nothing to do with the blood pressure that is measured on your arm when you're coming into the doctor. It's really just an isolated blood vessel system that has high pressure in it. And the two main reasons that this can occur in cirrhosis are related to changes in circulation and changes within the liver itself. So there's an increased resistance to the flow of blood through the liver when there is cirrhosis. So if you can imagine that scar tissue kind of scattered throughout the liver, that creates kind of like a slow drain phenomenon. So the blood normally can filter through the liver very, very readily, very easily. But when that scar tissue is kind of distorting that normal structure of the liver, the blood can still get through, but it does so with increased difficulty. So increased resistance to blood flow through the liver is one of the important contributors to portal hypertension. The other is an increase in the blood flow provided to the portal venous system. So increased flow and then increased difficulty in that flow getting through the liver result in kind of back pressure here in the portal vein. And this can affect the spleen and can result in development of blood vessels that we call collaterals or varices. These are really trying to decompress this system. So providing an alternate route for some of the blood to go around the liver instead of having to go through the liver. So one of the signature complications of portal hypertension that we see is ascites. So ascites is fluid that literally leaks off the surface of the liver. So if you can imagine, the blood is getting into the liver faster than it can get back out the other side. So the liver is kind of becomes super saturated with fluid. Some of that can ooze off of the surface of the liver and then can fill up the abdominal cavity. The fluid can be tested to look for things like infection with a procedure that's called a paracentesis, where a needle is inserted into the cavity where fluid resides. The way that we can manage this includes putting patients on a very low sodium diet. The more salt we take in the diet, the more fluid is retained, and this can be a really powerful way to help control ascites fluid. We usually use diuretics or water pills, and occasionally if the ascites really becomes severe and hard to control, then we will do a procedure where a shunt is placed inside the liver. That's called a TIPS procedure. The other signature complication of portal hypertension is the development of varices. So again, varices are blood vessels that form to allow some of the liver to, or some of the blood to bypass the liver, go around the liver. And so they do help to decompress that high pressure in the portal system, but they can grow large in size in certain locations, and in particular where we worry about their presence is in the upper intestinal tract, the esophagus, lower esophagus, and upper stomach. Because in these locations, if they grow large in size, the walls can weaken and these blood vessels can open up and cause internal bleeding. So often when we diagnose cirrhosis, we will recommend as part of the evaluation to do an upper endoscopy, or also sometimes called an EGD. This is an outpatient procedure, usually done with some sedation so that patients are asleep, if not very, very comfortable. And this flexible scope is placed down into the esophagus and stomach, where we can look to see if there are varices present, and if there are varices, do they look to be small and low risk, or do they look like they are at risk for a bleeding complication? And this is in cartoon form. You can see here the endoscopic view. As we're looking through the scope in the esophagus, we see these dilated blood vessels. Sometimes they can be a bit squiggly, as shown in this picture. So how do we manage these? How do we treat bleeding if it occurs, or prevent bleeding from occurring again? This can be done through the endoscopic procedure with placement of rubber bands over the columns of blood vessels that will scar those down so that they don't bleed in the future. We often also will use a class of medications called beta blockers. Now, not all beta blockers are effective for preventing bleeding, but the ones I've listed here will reduce risk of future bleeding. So those are often prescribed. And again, similar to our patients with severe refractory ascites, we will sometimes recommend placement of a shunt inside the liver called a tip shunt that will relieve the high pressure leading to these complications. Shown here, there is a site there's a longer YouTube video that is sort of directed towards patients and caregivers that can be helpful to watch if you're seeing the provider and they're concerned that your ascites is really severe, or you've had one or more variceal bleeds, that maybe we should think about placing the tips. This is a nice video to kind of walk you through all the steps of that. Likewise, this radiologyinfo.org website has a whole section on what a TIPS is and how it's done, what the benefits of it can be, and also some of the potential risks and the things that we do to evaluate people ahead of time to make sure that we are confident that this is the right decision. Okay, so moving now to a different type of complication. This is called hepatic encephalopathy. It's a bit of a mouthful, so we often refer to it as HE. And this is a condition that can be affected by portal hypertension as well. So if there's severe portal hypertension and a lot of shunting of blood around the liver through collaterals, then some of the blood isn't getting processed by the liver. Likewise, if the liver is getting sicker from cirrhosis and the liver cells aren't all working as well as they should, one of the things that can happen is that some of the byproducts of our digestion created by bacteria in the gut are certain things like ammonia and other things that we recognize as really not good for us to have circulating in our bodies, and certainly not to be getting into the brain. And so ammonia and some of these other toxins normally get cleaned out by the liver, so they don't get a chance to circulate to the rest of the body and affect us. But in cirrhosis, as it advances, one of the things that can happen is the blood doesn't get fully cleared of some of these toxins like ammonia, and when they're able to circulate in the bloodstream can affect us in a variety of ways. And I've listed here just a short list of some of the things that can happen in hepatic encephalopathy. So it can affect people's memory, their focus, their concentration, can lead to some confusion, can make people very sleepy or disrupt their day-night sleep schedule. So it can be pretty disruptive to people's quality of life. The management of this condition is typically with two medications. The first is a special type of laxative called lactulose. This is a sweet syrup that, in addition to sort of purging the gut of some of these things that we don't want to get absorbed into our bloodstream, it also can change the acid environment of the gut, the pH balance of the gut, in such a way that it's harder for ammonia to get into the body. The other drug that is used often in combination with lactulose is called rifaximin, and this is a special type of antibiotic that is not absorbed from the GI tract. So it lowers specific bacteria or types of bacteria within the intestinal tract, so that we're targeting the bugs that tend to make some of these bad actors that we don't want to get into the body. This is a condition that can be quite variable day to day, week to week, month to month, and can be triggered by other things happening. So if somebody gets a bad infection or develops an episode of internal bleeding, these are triggers that can make encephalopathy much worse. And then if we identify that, we can get that treated and get the encephalopathy back under control. Shown here on the side, these hands are demonstrating a physical exam finding that we call asterixis. So if your doctor is asking you to go like this with your hands, what they are looking for is a specific movement called asterixis or flap. where sort of involuntarily the hands can make this sort of a flapping movement. That's one of the signs we can look for to tell us that there may be encephalopathy present. Sometimes this can be, the encephalopathy can be subtle. So one more word about encephalopathy here, just to give you a sense of the spectrum of severity. So it can be very, very subtle, can be hard to identify, but in some cases it can be quite severe when patients are hospitalized. Sometimes this can land patients in the intensive care unit until we're able to get the encephalopathy under good control and back to safety. Next thing I want to review is the effect of advanced liver disease, advanced cirrhosis on our nutrition, our muscle mass, and our sort of overall strength, and put another way, the propensity of advanced liver disease to lead to some degree of frailty. So cirrhosis can impact nutrition in a number of ways that can result in loss of normal muscle mass. And so this picture here is a great example of what we will often see in clinic, where this individual has a large volume of ascites fluid in the belly. So the belly is quite protuberant, but you can see, the pants are just barely hanging on, and the arms can get quite skinny. So this loss of muscle mass is something that we look for because if we don't intervene and try to halt or reverse some of that muscle mass loss, people can start to become weak. We can see people have falls. This is in and of itself a marker of patients just not doing as well in the future. And so something that we have grown to be very attentive to as we're recognizing its significance. And in fact, researchers largely out of UCSF have developed a whole system to measure this, to evaluate this, particularly as we're seeing patients who are being evaluated for potential liver transplant, given that we know this can impact how well they do. So having patients in clinic do certain physical measurements, we can measure how tight their hand grip strength is, having them stand up out of a chair without using your hands to help you, or standing with your feet side by side or in tandem. And so there's a whole system available to help score this, to get a sense of how frail people may have become as a result of their chronic liver disease. So nutrition is really, really important. And I spend a great deal of time in my clinic talking to my patients about nutrition. This is one of those things that can be within your power to affect. And I think the more we can give you some control over your health and your well-being, that's an important thing to provide you with. So the tenets of nutrition, in very quick summary that I review with patients, include, as we mentioned earlier, watching to not consume sodium in excess. And if we're seeing a lot of fluid retention ascites, then we get to be pretty strict about how much sodium people take in the diet. Protein is very, very important. In the olden days, it used to be thought that we had to really restrict protein in patients with cirrhosis because it would cause complications. Now we recognize that that's not the fact, the fact in patients with cirrhosis, that in fact we want to make sure that they are getting adequate protein, and protein requirements can be quite high in patients with cirrhosis. Even if alcohol is not the reason that somebody got cirrhosis in the first place, we want to take it out of the routine so that we are minimizing any ongoing injury to the liver and optimizing the long-term health of the liver to the best of our ability. Bedtime snack is often recommended. Long periods of fasting in patients with cirrhosis can lead to more accelerated loss of fat and muscle stores. So those really, really skinny arms we see, we want to avoid that happening, and we can help offset that by taking some nutrition right before bed, and then having breakfast first thing when we get up in the morning. So we're interrupting the period of fasting. I put on here coffee. Coffee has emerged as something that has some health benefits for the liver. And so as I'm seeing patients with all varieties of liver disease, we'll ask them if they like drinking coffee. I certainly don't force it on people if they don't like it. But if you do enjoy coffee, that's one of those things that you can continue to enjoy with your cirrhosis. We do, in general, advise limiting highly processed foods. These can be high in sodium and other factors that just are not good for our overall health. There are some disease-specific diets that may pertain to you depending on your overall health and the cause of your liver disease. So, for example, patients with chronic kidney disease or diabetes or Wilson's disease or fatty liver may have very specific recommendations for the types of food that are optimal for them. And that is something I encourage you to speak with your provider about. And beyond that, maybe seeing if you are able to meet with a dietitian or get some sort of formal nutrition education, given that this can be a hard thing to change if we're recommending a diet that's quite different from what you've been accustomed to. I also listed nutrition supplement drinks because the protein requirements and caloric requirements can be high relative to what maybe people feel up to eating. Supplementation can be really important, and they pack the biggest punch, again, when taken at bedtime. So I said in the beginning that cirrhosis does not mean cancer, and this is true, though we do recognize that having cirrhosis can place you at a little higher than average risk for developing liver cancer. Because of that, we routinely recommend some sort of testing to monitor for development of cancer in patients who have cirrhosis. And shown here is an example of an ultrasound and a CAT scan that demonstrate a mass lesion in the liver. So the term surveillance, this means that we know that somebody is at risk for a specific problem or complication, and that we want to keep eyes out for that happening by performing testing, even though they may have no symptoms or signs of cancer present. And the surveillance for liver cancer in patients with cirrhosis is done with either an ultrasound or other imaging studies. The most common alternative to an ultrasound that is emerging is what's called an abbreviated MRI or a shortened MRI, which is something that was really pioneered by some of the outstanding radiologists at UC San Diego here in town. So these scans of the liver can help identify cancer early when it happens. Though we have to be careful, sometimes these tests that are used for surveillance are not necessarily diagnostic. So they can show us that there's something in the liver, but not necessarily tell us definitively, is that something truly a liver cancer or is it something benign? So in addition to the surveillance tests, we have diagnostic tests. So these are follow-up tests to the surveillance or screening tests that could help us say, you know, is what we see here truly a cancer or not? And the importance of doing this is because we actually have a lot of different treatments that can be offered for liver cancer should we find it. And shown here, I won't get into the details of this, but just so that you recognize that there's a lot of things that we can do to treat liver cancer, including treatments that can be curative. The key is finding it early, and that's why getting your scans done every 6 months is of utmost importance. We really harass our patients we're seeing at the VA to get their ultrasounds done, get them done on time. So how do we treat cirrhosis once we've identified it? And I put here sort of the categories of things that I like to address with my patients in clinic who have cirrhosis. So the first thing we want to do to the best of our ability is to understand any and all things that may have led to cirrhosis developing in the first place. So what are the risk factors for liver injury, chronic liver disease? Are there factors ongoing that we can in fact kind of target to stop any additional injury? We want to stabilize the cirrhosis or even make the cirrhosis better. And we can do that often most effectively if we find a treatable cause of liver injury that we can reverse. And I've given some examples here. This could be treating viral hepatitis, can be abstaining from alcohol use. In autoimmune conditions, it can be adding certain medications that can reduce inflammation in the liver. So this is why it matters to us to really do a full investigation to understand why cirrhosis developed in the first place. We want to both look for and effectively manage complications of cirrhosis. So the things that we just reviewed, ascites, varices, encephalopathy. We want to look to see how these things developed, how bad are they, and how can we most effectively manage them so that we are optimizing to the best of our ability your quality of life, in addition to your long-term survival. There are what we call aggravating factors. So again, the example I gave, maybe your cirrhosis is not from alcohol, but you were used to having, occasional alcoholic beverage. We would just say, let's cut all that out because we want to avoid anything that could harm the liver at this point. In addition, looking at things like nutrition, physical activity, exercise can help promote good liver health regardless of the underlying cause. And we are very pro immunization in our liver clinics as well, which I'll review a little bit further. Finally, in terms of reversing the cirrhosis, there are examples of patients with cirrhosis that's diagnosed or identified very, very early, where treating the underlying cause can actually lead to some reversal of the scarring to a point where the liver may no longer be cirrhotic. Some of the best examples of this would be patients who have cirrhosis purely due to hepatitis C infection or hepatitis B infection, who we are effectively able to cure with antiviral therapy. And certainly liver transplantation is also curative for cirrhosis in patients who require that. So treating the underlying cause. Here are examples of underlying causes of liver disease that can lead to cirrhosis that we may have directed therapies for. So I just mentioned viral hepatitis, autoimmune liver disease. The treatment for alcohol-associated liver disease is really attaining abstinence and treating the underlying alcohol use disorder to the best of our ability. Non-alcoholic fatty liver can be addressed largely through lifestyle, although with some new medical therapies, medications emerging with great promise. For some of the inherited conditions like Wilson's disease or hemochromatosis, there are also treatments that we can offer that can help stabilize or improve liver disease. This is taken from one of my favorite websites, done through the Veterans Health Administration. It's hepatitis.va.gov. Lots of good resources on there, and they're available to you even if you're not a veteran. And this is a great sort of checklist of simple measures that you can take to try to help keep yourself well, not using alcohol or any drugs, taking the medications that are prescribed, and really trying to steer clear of things that you do not need, given that every medicine we put into the body has to be processed by the liver. So let's not throw anything at the liver that it really doesn't need. Avoiding certain pain medications, including the non-steroidal anti-inflammatories like ibuprofen. We do say that Tylenol is okay, which sometimes is surprising to people, but we do have to be really mindful about the dose taken and to not combine it with alcohol. Also being very careful about medications that are sedating, like sleeping pills, tranquilizers, even certain pain medications that can exacerbate complications like encephalopathy. Just a few words about immunizations and cirrhosis. I mentioned previously that we are very pro-immunization as a way to be proactive and avoid what can be life-threatening complications. So shown here is just a snapshot of immunizations recommended for all adults. And what I've highlighted is simply that none of these are vaccines that are prohibited or considered to be high risk to give to patients who have cirrhosis. So it's okay to get your flu shot, your Pneumovax, your shingles vaccine, whatever it is that your primary care says, hey, you're due for, we are supportive of. I'll also say that we're very proactive about immunization for viral hepatitis. So let's say your cirrhosis is not from a virus, but from some other cause. If you are not immune to that virus, you become infected. That can be very serious. It can cause people to die. So this is a way for us to try to protect people's health over the long term. So one of the most important ones we really try to push for our patients is hepatitis A. So hepatitis A is a virus that can be spread without necessarily high risk behavior. You can get this from your hands, you can get this from food and drink. And we had an outbreak in San Diego really not all that long ago, and as well as other parts of the country. So hepatitis A immunization is a big one that we want all patients to have. You can be tested to see if you're already immune, and if you are, then you're good, you don't need it. If not, then it's a series of 2 shots. Hepatitis B is another big one that we encourage everybody to be tested for and to offer immunization. There are some expanded options for immunization, including a highly effective series of 2 shots. The traditional series is a series of 3 shots. So this is another big one that we encourage for our patients. Finally, a lot of patients have questions about the new vaccines that we have available for the coronavirus, COVID-19. And so I'm sharing with you some language from our US Professional Society for Liver Disease, and one of the big advocates for patients who have liver disease. And based on really very good evidence, we are recommending that all patients with liver disease, all patients with cirrhosis certainly, undergo vaccination for COVID-19. And also shared with you a study done in our veteran population, over 20,000 veterans, and looking to see how did people with cirrhosis fare after getting 1 and 2 doses of the vaccination. And you can see that if you got the 2nd dose, that your risk of severe complications, hospitalization, or mortality is dropped very, very quickly after receiving that 2nd dose. So really encourage you to pursue immunization if you have not done so. So let's talk about liver transplantation. This is a common question that comes up when we have identified somebody as having cirrhosis. So do I need a liver transplant? And so the questions that we look at as liver providers to help address that are, have you had any complications of cirrhosis, or is your cirrhosis entirely compensated? We look at something called a Meld score, which I'll explain. Sometimes we use transplant as a means of treating liver cancer. And there are some other sort of a potpourri of uncommon complications that may lead us to recommend transplantation. So again, this whole concept of, is the cirrhosis compensated versus decompensated? So in compensated cirrhosis, unless we are seeing evidence of liver cancer, typically we would say you are better off with the liver you've got than to think about undergoing a massive surgery and taking medications to protect a transplanted organ. So we really look at this for our patients who have decompensated cirrhosis, because that really changes our understanding of their prognosis. And The way that one of the ways that we help determine someone's need for transplant is through calculation of this score called a Meld score, MELD. And shown here is a snapshot from the transplant organization here used in the United States, the OPTN. And so you can Google Meld's calculator and it'll take you to this site or other Meld calculators, and you plug in your some of your lab values, the bilirubin, serum sodium, creatinine, and INR labs, and those are used to calculate a score. And I'll show you in just a moment kind of what that score roughly tells us about where people are with their cirrhosis. On this particular calculator, you'll see that they're asking for age or date of birth, and this is really because this would address both pediatric and adult transplant, which have little different scoring systems. But typically, we don't take age into the Meld score itself. So as the higher the Meld score goes, the sicker the liver is, and the higher the risk somebody faces of dying from complications of their liver disease in the coming 3 months. So this is how we really look to these scores to guide us. And shown here are some different Meld categories. So a very low Meld score, a Meld score under 10, really you're kind of at home, not hospitalized, not sick. You look just like anybody else looks. This is the sort of the earliest stage of cirrhosis. When we're getting in the 10 to 19 range, again, typically these are people who often don't require hospitalization, so they're at home and seeing us as outpatients in clinic. Once people start to get Meld scores up into the 20s is often when we're seeing them develop complications that may require intermittent hospitalization, and where we are often thinking very carefully about whether we can offer transplantation for these individuals. When we cross the threshold into the 30s, these are patients who are becoming very, very sick. Not unusual for them to have spent time in the intensive care unit. And once we get into a score of 40, where we're kind of maxing out on that Meld score, these are people with very, very limited life expectancy without urgent transplantation. Unfortunately, sometimes patients who are scoring this high start to become really too sick to even take to a transplant if their liver disease is so advanced that even a surgery would be deemed unsafe for them. So pretty wide spectrum of what this can look like. Just to give you a sense, where do people, what sort of Meld scores do people have when they get a transplant? This is relatively recent numbers here from this year, looking at our 2 transplant programs here in San Diego, Scripps and UCSD, and the median Meld score at which people are transplanted here is 33. These are patients who are pretty sick when they're having their surgery done. Okay, so all that flurry of information, I want to encourage you to put some planning, some thought into your visit with your liver provider. I think we often, myself included, we go into these visits and we've got in our mind all the things that we want to review, and we sit there and we listen and think, okay, I take it all in, then you walk out of there and you have a hard time sort of recalling what all was reviewed and discussed. So I think coming prepared, bringing, if you're able to, another set of ears to witness and help digest what you're being told, taking some notes, are all really helpful tricks to get the most out of your visits. And so I've written down what I think are some really reasonable questions to bring to your clinic visit when you see your liver provider. And so as we've discussed here, understanding, do we know what caused my cirrhosis, and are there any treatments that can be offered for that underlying cause of liver disease? Is my cirrhosis compensated or decompensated at this point? Do I have evidence of portal hypertension? What is my Meld score, or what are the labs that go into my Meld score? Many of us have access to a lot of our test results through patient portals, and so you can log on at home and plug those numbers in. Though sometimes it's good to review it in the setting of being there with your provider, so you can really review, hey, I got a 12. Is that good? Is that bad? I can't remember. Is it good to have it high or low? So sometimes just doing that in the presence of the liver provider can be more helpful. Am I immune to viral hepatitis? If not, can you vaccinate me? What medications should I be taking, and what things do you want me to steer clear of? What sort of diet do you recommend for me, and do you have any resources you can give me to understand and adhere to that diet? Do I need a transplant now? If not, do you think I'll need one in the future? We don't always have the answer to that, but sometimes we have a sense, and we can share that with you. What am I due for my next liver cancer surveillance scan? And do I need an upper endoscopy? I think those are all really fair questions. You don't necessarily have to do them all in one visit, but I think that those are important things to touch upon and have a good sense of, so that you've got a good handle on where you are with your course of disease. So from here, I'm going to just share with you some educational resources. Many of us, myself included, we'd like to read up on our own, try to get a handle on things. And again, there's some good information out there. There's also some information that can be either misleading or confusing. So I mentioned this site before, the hepatitis.va.gov site. You don't have to be a veteran to access this. So even if you're not one of our veterans, you're welcome to cruise around this. There's a lot of really, really good information on here about cirrhosis, about other types of chronic liver disease. And so good resource for information. The NIDDK, which is one of the branches of the National Institutes of Health, has a great deal of information on their website as well that is really directed at patients and at caregivers, so that it's not using a lot of medical jargon that can be hard to follow. The Centers for Disease Control and Prevention, or CDC, also have a lot of patient information, particularly a lot of good information about viral hepatitis and vaccinations. The American Liver Foundation has a whole host of brochures and videos about different types of liver disease here, including an overview of liver cirrhosis. And I think that takes us to the end here, where I just want to leave you with the thought that knowledge is power. Again, it can be very overwhelming to get this diagnosis. And I think the better that you feel like you have a handle on what it means, and also what you can do proactively to help protect your health, that can leave you feeling empowered, which I think is really important, good for your quality of life. Okay, thanks very much. I'd be happy to address any questions that you have.
Dr. Patton, that was a fantastic presentation. You're always a joy to listen to. You give us such practical advice and information, and I know the patients that are, or the attendees really just had a wealth of information. So thank you for your time, your consideration, and your passion for taking care of liver patients. With that said, we do have several questions. And so I'll go ahead and start with them. The first question is, how often should a patient get a fiber scan after the initial one? And do further fiber scans show the progression of fibrosis?
That is a great question. So what are the beauties of FibroScan is how safe and quick and easy it is. And that really lends itself to repeating it over time in circumstances where we think that can be helpful. So to give you some examples of when we may do repeat FibroScans, this can include the following. We sometimes use FibroScan in people who we know without a doubt they've got cirrhosis, but we're trying to judge how at risk they might be for varices. So sometimes using the FibroScan can help guide us as to whether we need to put someone through an endoscopic examination or whether we can delay that. And if we're using it for that purpose, then typically we would repeat it once a year. In other situations, we may be wanting to sort of restage someone's disease. So maybe we think that they have a degree of fibrosis that is close to, but maybe not quite at a level of cirrhosis. And we want to, over time, see has there been any progression, or on the flip side, any regression, any lessening. And in terms of the time scale, this is not something done super close together. It takes some time to see things change in a meaningful way in the liver. It is, I'll tell you, in my practice, it's unusual to do FibroScans closer than a year apart. And sometimes it's more like after 2 years or longer. One of the exceptions can be sometimes when I meet patients the very first time, maybe if they've just been diagnosed with severe liver disease related to alcohol, and maybe they've just entered abstinence and have a pretty short amount of sobriety. If I check their FibroScan right in that moment, a lot of times things can look pretty bad. And if we recheck them after some period of sobriety that can even be on the order of 6 months or 9 months, things can look very, very different on that time scale. So the answer is so many.
I think we have a little bit of buffering right now with the internet. Hopefully no lightning strikes right now.
It depends on what we're looking for, but yeah, we do repeat them because things can change, things can be dynamic. Our old-fashioned liver biopsy.
Great. I think I lost Dr. Patton.
I'm going to turn off my camera if we're
yeah, there was a little buffering and hesitation.
Can you hear me?
Yes. Yes.
Okay.
Okay. So actually, this leads to another question, Dr. Patton. The question is, can you go from decompensated to compensated cirrhosis with appropriate treatment and lifestyle interventions?
Great question. And the answer is yes. So we often refer to this as recompensation. So again, using the example of alcoholic liver disease, patients who become sober, after a period of time, we can see a great deal of recovery occur. And so people may start off by having a lot of ascites, and over time that could become less and less and go away. This is true for other etiologies of liver disease as well. I think often the time scale we can see things improve from alcoholic liver injury tends to be maybe a bit more rapid, but it can occur in other types of chronic liver disease too.
Yes. You know, many patients complain of problems sleeping, and you talked about that with HE. One of the questions is how can they manage that? They want to know, is it okay to take melatonin and maybe CBD gummies to help with their sleep?
Yeah, this is a common question we get from patients. Sleep is so important to our health and our well-being, and it's really upsetting when we are feeling like we can't sleep or get adequate sleep. So the first thing that I recommend to patients is certainly to make sure that if you have encephalopathy or think you might have encephalopathy, that the medical management of that is optimized because, as I mentioned, if not, that can itself disrupt sleep. So making sure that you are optimally dosed on lactulose, and that if you need rifaximin, that you're on that as well. The second thing is the simple lifestyle things that you know, sometimes we poo-poo, but are really important, meaning that you are getting some daylight during the daylight so that we naturally are engaging our own melatonin in the body. That happens on its own, but not if we're not giving the body the right cues. So getting some daytime light in the morning, at the end of the day, can help sort of set our body clock, if you will, so that can engage some of the natural melatonin. Also, all these screens that we use, if we're using them late at night or during the night, these really can cause issues with good sleep. This is, generally what we call sleep hygiene. So these little lifestyle tricks that can influence sleep. If these types of things are not getting you a restful night's sleep, then I typically am okay with my patients using a melatonin supplement. Regarding CBD, I'm not opposed to it, although I will say relative to a lot of other things, we're pretty naive as to what it does, how it works, are there any safety concerns? So it's a little bit more of an unknown relative to some other agents. And many of us in medicine get a little worried when we don't have a lot of information, how something might work or what unforeseen complications might be. So on the CBD front, I would say that's a good question for your provider specifically, and to see if your particular provider has any concerns for you, but it's a bit of uncharted territory. Some of the other sleep agents are ones that we get a little bit more worried about, some of the typical sleeping pills, if you will, in that they have to be metabolized by the liver, and sometimes the liver isn't metabolizing them as well. And so you can have prolonged effects from them, or it can trigger or exacerbate encephalopathy.
Great, thank you, Dr. Patton. There's another question that just came in. Do you ever see patients who develop neuropathy or itching as symptoms of their liver disease?
Yes, great question. So we do see neuropathy not infrequently in our patients with liver disease, and not necessarily because the cirrhosis is causing it, but because of some shared risk factors. So for example, going back again to alcohol, we know that alcohol can damage the nerve endings, and so alcohol can cause neuropathy, and it is pretty common for me to see patients who have liver disease from their alcohol that also has resulted in neuropathy. Likewise, one of the other really common causes of neuropathy is diabetes. And we see that not uncommonly in our patients in liver clinics. So sometimes the diabetes has resulted in neuropathy. Again, not usually a direct result of the cirrhosis, but maybe a common risk factor. And that's something that can be tested for. So if you suspect or think you've got neuropathy, then there are tests that can do to confirm that. And there are medications that can help in managing the pain that can come with some forms of neuropathy. Itching is another one. There are certain types of chronic liver disease that are pretty notorious for causing itching. These are typically diseases that affect the bile ducts. So things like primary biliary cholangitis, primary sclerosing cholangitis, these often can cause itching. Additionally, sometimes in more advanced cirrhosis, we do see that maybe the bile isn't being handled normally or efficiently by the liver. And when the bile sort of gets more hung up in the liver, that can sometimes be associated with itching as well. Itching can be a very difficult symptom for people to manage, and I 100% encourage you to bring this up with your liver provider if you're experiencing it. There's not one right answer as to how to treat it, but a lot of different things that we can try. And so for sure, speak with your provider if you're experiencing itching.
Great, thank you, Dr. Patton. Well, I think that is all of the questions that I see on the poll right now. I would like to thank you again for your tremendous education that you provided for us tonight. I think you gave us some really practical tools to utilize so that when we see our primary care providers or our liver providers, that they feel that they're empowered, they can go in and ask questions. So again, thank you for your expertise, your knowledge, and your dedication to our liver patients.
Thank you so much. It's my pleasure, and I sincerely hope that those of you watching the webinar take away something that's helpful to you in speaking with your doctor. Thanks very much.
Fantastic. And I'd like to let our attendees know this information. We have several webinars with the Liver Coalition of San Diego. So please, share this information with your friends so that you can get knowledge from experts in our field in the San Diego area. And we look forward to you attending another presentation with us. Take care, everyone. Have a good night.